Okay, this is the second video for Unit 6, the hematologic system. We're continuing from slide 80, iron overload. Once again, iron is highly reactive. It has a +3 electrical charge that makes it in need of electrons. It's starving for electrons in a chemical way, and it's going to cause those cells to be highly reactive, right? So you can see that we have the HH, which is the inherited form, and we have the SH, which is the secondary form that is an outcome of something. Um, don't I think that the secondary part you already understand. It's pretty simple to get. You can see the reasons: insufficient erythropoiesis, dietary iron overload, meaning you're eating uh, a lot of food that includes a high content of iron, um, injections of iron, uh, or repeated blood transfusions that increase the amount of iron in your body. Let's start with the HH first. Basically, it's an inherited form. It's recessive, meaning that you need two defective copies of the gene, one from each parent, to actually be sick or have the disorder. Um, Basically, your gastric intentional tract absorbs uh, more iron than it needs. And of course, you're going to have increased deposits of iron in your tissue. Um, so these large amounts cannot be counteracted, leaving iron unsupervised, so to speak. And you probably know what the next thing that I'm going to say is. And that is that you know what the next thing that I'm going to say is. Just messing with you. That's a bad idea. Leaving iron uh, alone, unchaperoned, unsupervised is a bad idea. Um, okay, so you have basically the inherited part of it, you have the secondary part, and we can go on to alterations to white blood cell functions. Once again, same principles, very simple to follow. Any alterations, changes to amount, structure, or function. Um, to pinpoint the bottom line, you're altering the function of the adaptive immune system. So, leukocytosis can be defined as an abnormal high amount of white blood cells, or leukopenia is the opposite and is a low count of white blood cells. Notice that we're using white blood cells. There's multiple options of white blood cells that can be influenced, and it can be caused by physiological reasons or non-physiological reasons. Remember that an increase in the number of white blood cells is normal under normal conditions. Exactly like the elevation of systolic blood pressure is normal during exercise, or the elevation of heart rate during exercise is normal. So that's not always an indication of a problem, right? So the increase of an immunoresponse could be the right thing if you have inflammation, if you have an infection, and it's not necessarily a bad thing, right? So you see the list of causes uh, that can occur. On the other hand, A low count of white blood cells is never regarded as normal. And you can see the numbers, and I do want you to remember them if you don't mind. And that can be also caused by treatments such as radiation for cancer and chemotherapy and so on and so forth. Um, then on slide 92, we're talking about alterations to granulocytes and monocytes. Um, Basically, these two go up when you have some kind of invasion, uh, but can also be the result of a disorder, right? That will cause uh, um, per- proliferation of these cells. If they decrease, it's a clear sign of an infection causing a balance between production and extraction from the circulation. So, as you know, white blood cells are constantly roaming blood circulation. They can go in and out of tissues, back in and exit from the bloodstream. So, you might have an imbalance between the amount produced and the amount that is in the circulation at any time. Most likely, you have some kind of suppressive process going on in your bone marrow. Um, let's see. You can see the threshold of 7,500 as an indicator for the count of an abnormal release into the blood. Then, once the cells are released into the blood and you don't have a matching process to produce new cells, then with time, you're going to have a deficit of mature cells. So you have premature cells being released. You're not creating mature cells. You're not letting them mature. So you have a decrease of that. When you are able to replenish mature cells, it's called a shift to the right. When you're not, it's a shift to the left. What else? Basically, you see multiple options of cells and their changes according to the conditions. Something that I think is relatively simple to understand. I don't think you need to remember every cell and how it changes. Slide 100, alterations to lymphocytes. Um, the increase in lymphocytes is usually an acute response to a viral infection. You can see that usually is due to the EBV virus. Um, of course, a decrease is definitely abnormal always and is due to the lack of production or increased destruction because of therapy, any kind of therapy. Um, then you see that usually elevated levels of cortisol uh, are associated with heart failure, uh, have also been associated with a decreased lymphocyte count. I think it's pretty obvious that if you have a suppressed immune response, you're in increased risk to cell injury of different possibilities. Then we can talk about IM, uh, the acute infection, in this case of a specific kind of lymphocyte, which is the B lymphocyte. It's infected by EBV, um, and can also be caused by another virus, which is CMV. I would remember the EBV more than anyone else. You see that EBV is transmitted via saliva during close personal contact. That can also include someone that spits when they talk and is talking really close to you, and they spit. And when they talk, part of their saliva enters your system. Um, what else? You can see that the immune system responds, leading to swelling of the tissue, sore throat, and fever, early flu-like symptoms, joint pain, cervical lymph node enlargement. So these are a bit, they're not completely unique symptoms, but they are relatively unique to this condition. And then you can see that IM can lead to death if your spleen erupts. It can be self-limiting in some cases, like a lot of viruses, and it can lead to full recovery within weeks. Okay, so it can be self-resolving, on one hand, and can cause death on the other. Okay, qualitative alterations to leukocytes. Uh, we can talk about obviously cancer, and you see that we're not going to go into specific types of cancer. I don't feel there's a need to that, but we can talk about in general, just go around it and talk about leukemia. I felt that it would be nice, not nice, but important to talk about leukemia because it's very common, but it's not the only kind of cancer there is, just probably the most common one. So you see, it's a clonal malignant disorder of the blood or blood forming organs, uh, uncontrolled amount of malignant lymphocytes. If you remember, when we talked about cancer, we talked about one of the advantages of cancer being that it's able to infiltrate the immune system and affect the cells themselves and hide within the immune system. So this is exactly what you're seeing here and what we're talking about. You can see that the classification of leukemia is according to its origin and what is the predominant cell type that it's affecting, and of course the degree of differentiation. So you see the four subtypes: ALL, AML, CLL, CML, and the two first ones, the A is for acute, the two second ones, the C is for chronic, and then once again it goes lymphocyte, myelogenous, lymphocyte, myelogenous. Okay, so it's basically two main types with a chronic and non and acute form. Um, so you can see that acute leukemia is mainly characterized by immature blast cells. Usually, it occurs fast and strong, with a negative prognosis and a short duration, meaning there's not enough time to take care of it. Chronic leukemia is characterized by more mature cells with some kind of dysfunction within it. So it's matured, but it's non-functional. And with time, the onset is slower and more treatable. Obviously, leukemia has become more and more treatable with time, whereas once it was way more deadly. Still considered idiopathic. And then you see the very long risk factors uh, that are very long but very unique as well. So long on one hand, unique on the other. Um, we're talking about cancer. We know that we have biological risk factors and we have environmental. So you have the list of environmental risk factors. Um, trying to see if there's anything that's really important that we haven't talked about uh, in Unit 3 about cancer, and I can't see any. So I'm going to advance to slide 119 and talk about alterations to lymphoid function. And then you can see a lymphadenopathy, which by definition is an enlarged node due to increased germinal center size and numbers, meaning you have an imbalance of germs in a specific node that is causing it to be enlarged. Um, Bottom line, an invasion of malignant cells into the area, which are enlarged cells, cause this condition. You can see that the unique symptom is the node, the area being palpable, tender, and painful to touch. So you touch certain areas where you have nodes and they hurt, they're tender, um, and you can actually feel it there. Um, of course, nodes are associated with the idea of drainage, right, of the lymphatic system. So you have some kind of problem with drainage uh, of an infectious or inflamed lesion. What else? You see that we have the causes being divided into four main options: neoplastic disease, uh, something with the background of the immune system, an endocrine imbalance or hormonal imbalance, in other words, and then you also see lipid storage disorders. We can continue to alterations to splenic function. Obviously, we're talking about any organ that has a direct and indirect effect on the on white blood cells production or function. So you see that we're talking about splenomegaly, and you can see that this is not necessarily a pathology. It can occur without a disease, but it's a first sign, one of many other conditions, uh, and that's why it's kind of like a early alert to make sure that nothing else is going on. Um, Usually, you'll see in the background anemia, leukopenia, thrombocytopenia, uh, or any combination of them. So it's usually, it would be uncommon, let's just say it that way, or unlikely for it to happen without any kind of background, meaning it's usually secondary. You see that the primary form is idiopathic. Um, then you can see that when it gets worse, it's going to affect all three blood components, reducing the cell count. You have the extent of the spleen size and spleen blood flow, results in destruction of the cells themselves, and anemia. So atrophy, decreased blood flow, supply of nutrients and components needed lead to the destruction of cells. Um, Now we have another uh, optional problem of function, and I think it's pretty simple to understand. And that is those are alterations to platelets and coagulation factors. So obviously, coagulation factors mean that you bleed more. Platelets play a cardinal role, a central role in the healing of injuries, and it's pretty simple to see where this is going. So basically, you have in this case lack of sufficient platelets or coagulation factors, um, and it's going to result in influencing the healing process, right? So you see, we have pseudo thrombocytopenia, which is the result of a mistaken blood sample analysis leading to a diagnosis of a pathology. So obviously, this is a lab mistake, in other words. Then you can have a massive transfusion of platelets, uh, poorly packed cells for the treatment of hemorrhage, may also cause pseudo thrombocytosis. It may also be stimulated by splenic requesting of platelets with hypersplenenism. Um, and then someone can also be predisposed due to genetic reasons or body temperature returning to normal after it was abnormal. So obviously, the imbalance is always, or the outcome is the balance. The net outcome is the balance between production versus consumption or destruction of the platelets. It could be, as usual, acquired or inherited, primary or secondary. We see that acquired is usually due to nutritional intake, an autoimmune disease, or some kind of infection, and that's kind of the basic bottom line of any acquired problem. Of course, any kind of therapy, chemical therapy, can influence that as well. Then you see that we have HIT, which is a specific form that is induced by drugs, which is heparin dependent. You can see that it's usually associated with surgery, nothing new here, and mediated by some kind of immune response that makes it worse. Then you have untreated HIT, which is obviously going to get worse. You have the idiopathic or the immune form of things that naturally originates from the immune system. It can be acute or chronic, and usually the acute form is secondary to an infection. You see that the primary form is the chronic form. Nothing much here to add. Basically, it's a very simple idea. Then you see that we have TTP, the multi-system form of the condition, and obviously when it's multi-system, it's life-threatening. and more severe. Okay, I'm going to stop here and we'll continue from slide 142.